In our today report, we are going to present two rare benign tumors. One of them is clear cell acanthoma. Originally, it was thought that it is a rare benign epidermal tumor of unknown etiology, but recent studies suggest that it is a rare reactive inflammatory dermatosis. And the other one is pseudolymphoma, which is reactive lymphatic proliferation appearing in the skin and resembling a malignant lymphoma. Both of them are rare and benign. Both are looking as non-specific papule or plaque, but both present a problem for differentiation as well for a possibility of pseudolymphoma can transform into malignant lymphoma. Differentiation between cutaneous pseudolymphoma and cutaneous lymphoma requires the complete synthesis of clinical, immunohistochemical, and histopathologic and molecular data. In many situations, patients need to be followed over time, particularly patients who present with a solitary small lesions, to determine which diagnosis fits best. Especially given that many cutaneous lymphoma can take months to years to fully manifest themselves clinically. Therefore, dermatoscopy is really important, which has found quite wide application in clinical practice in recent years. Allows not only to conduct a more accurate assessment of pigmented and non-pigmented skin lesions, but it's important for surgeons since it helps to more clearly define two surgical margins. Digital dermatoscopic images were captured with a dermatoscope DermLite DL3 mounted on digital camera Galaxy S4 Samsung Corporation. And ultrasound gel was used for immersion dermatoscopy. All images were evaluated using algorithms of Harold Kittler and Cliff Rosenthal. What is clear cell acanthoma? Clear cell acanthoma, which is also known as Dego's acanthoma, is rare epithelial benign tumor with unknown etiology, predominantly located on the legs of adults, mostly those in their 50s or 60s without any gender, racial, or ethnic preference, and it may persist for years with slow growth. Such lesion is mostly solitary, with pink-brown coloration, slightly elevated on the surface and looking as a dome-shaped papule or plaque, sometimes with peripheral scales and even superficial erosion. Maybe just because of such appearance, it has also been suggested that this lesion is an inflammatory psoriasiform dermatosis. And it's difficult to differentiate these lesions from irritated seborrheic keratosis, Bowen disease, pyogenic granuloma, amelanotic melanoma, and basal cell carcinoma. Diagnosis is always based on histopathologic examination. Epidermis with psoriasiform acanthosis containing large, pale, clear keratinocytes in the main histopathologic finding, and a sharp demarcation from the surrounding epidermis is the rule. In our cases, the patient of 53 years old had a pink, shiny, well-demarcated lesions located on inner side of the leg, looking as a solitary plaque about 20 millimeter in diameter with peripheral scales and stark round edges. This lesion appeared 2 years ago and grows slowly without any subjective claims. And it was treated without result as psoriatic plaque with topical steroids. During the dermatoscopy, which was captured with DermLite DL3 dermatoscope using an ultrasound gel, and when all found images were evaluated using an algorithm of Harold Kittler, we received that the most characteristic was the pattern of the blood vessels. On the periphery, it is linear, and the part of and on the center part, multiple dotted vessels were arranged partly in linear, pearl-like distribution and partly in reticular appearance. These dotted vessels, which represent the dilated capillaries, oriented mainly perpendicular to the skin surface in the elongated dermal papillae. Form the reticular appearance due to the regular distribution of the surface. Additionally, the multiple dotted vessels were circumscribed by a translucent colored scaling. In the pathology, and additional dermatoscopic features is pale pink background and shiny white lines. And in pathology, images are seen acanthotic epidermis containing larger than usual keratinocytes, well demarcated from adjacent epidermis. Also, hypergranulosis, minimal nuclear pleomorphism at vessels within the dermal papilla dilated, torches and run vertically up the papillae. And our second case is a pseudolymphoma of the skin. Pseudolymphoma of the skin are a reactive process with accumulation of lymphocytes in the response to the various irritants. This can be a bacterial or viral infectious agents, drugs, exogenous agents. The problem is that pseudolymphoma stimulates lymphoma. These distinctive features of pseudolymphoma is benign course with a tendency to spontaneous resolution with the exclusion of exogenous and endogenous factors. But the question of possibility of their transformation into the true lymphoma is still debated. Clinical differentiation from the primary cutaneous lymphomas, sarcoidosis, leukemitis, or even non-ulcerated basal cell carcinoma is difficult. Therefore, the diagnosis of the pseudolymphoma is one of the complex tasks in dermatology, and dermatoscopy can help the clinician in this problem. The second case is the healthy woman of 37 years old with complaints of quickly growing solitary papule, pink, dome-shaped with sharply demarcated borders, measuring 7 by 7 millimeter. And under dermatoscopy examination, observed pink background, homogenic structureless pink areas, multiple linear branching and non-branching vessels with reticular white lines, and no causing pattern. And histologically shows a nodular inflammatory infiltrate in the dermis, and infiltrate containing well-formed germinal centers limited to the papillary and upper reticular dermis favors pseudolymphoma. The key histologic features that favor pseudolymphoma include the presence of a mixed infiltrate that includes histocytes, eosinophils, and plasma cells, in addition to lymphocytes. No deep invasions, no cellular monomorphism, and no prominent sclerosis. And thank you for your attention.